Welcome, friends. This is Dr. Jaitly, your cardiologist from New York. I want to thank you for being on MuniMeterHealth to watch our video channels, primarily geared towards human heart awareness and cardiology. We are improving medical education and patient education simultaneously, uniquely on the site, in order to improve the clinical outcomes, as we have discussed several times earlier. As we always do in short video vignettes, we like to delve into the subject matter. Today, we're going to be talking to you about a very exciting treatment that has evolved for high cholesterol, if you will. And we know for ages now, literally for decades, if you will, statins have been around. And second, third generation statins, where the liver toxicities have been lessened and the effects are more, from simvastatin to atorvastatin to rosuvastatin, and the like. But now we have a new mechanism where cholesterol can be lowered, and we know that the particle that's responsible for all atherogenesis is the LDL particle cholesterol. So if that is very, very high, then we have a problem. So all mechanisms to lower LDL have been centered around mostly in the statins armamentarium so far in the past 30-40 years. But now we have a brand new breakthrough, if you will, and that is on a drug which is acting on PCSK9. Now, statins were acting on HMG enzymes, and therefore they were HMG co-inhibitors, if you will. So that's how the statins really worked. But PCSK9 is an enzyme, and therefore that needs to be inhibited in order to successfully be able to bring down the cholesterol or the LDL-C particles. Now let's understand how the PCSK9 works. So that's the whole idea, wanting to go over this in the video. So let's draw the liver here, if you will. And if you draw the liver using my favorite color, for instance, okay, and we have the arterial flow, which is traversing here. For instance, this is your say the hepatic artery, which is bringing the blood rich in LDL after your lovely meal, or rich meal rather, I should say. So normally LDL is present in the blood, and anything up to 100-110 is still considered fairly safe in normal individuals, okay, not knowing that they have any coronary artery disease, etc. I'm just saying LDL has a number there, and that's about 80 to 110 is pretty still good. Now, there are LDL receptors which are present on individual hepatic cells. So these are all your hepatic cells, and LDL receptors, what they do is they have the affinity to take up the LDL right there. As the blood is traversing through the liver, imagine this artery and these small arterioles traversing through the liver, LDL is taken up by these LDL receptors. There are numerous millions of receptors all over the liver surface. Now, LDL therefore now goes within the hepatic sites or within the vesicles. There are vesicles and there are hepatocytes. These are hepatocytes or hepatic cells, if you will. So we'll say for our practical purposes, we'll talk vesicles and hepatocytes here. Now, most of the LDL will be taken up by these hepatocytes and vesicles and be metabolized. So this way, some of that LDL is degraded and it passes into the bile and removed from the body. So there is a little depletion. There's a substantial depletion of LDL through the bile, but some of it will be recycled back into the blood. So the net result is LDL is low when the blood is leaving the liver. So when the blood is coming into the liver, obviously it's rich in LDL, but as it's leaving, some of the LDL has been degraded and passed into the bile. So obviously there's a depletion within the LDL pool, quote unquote, and some of that LDL is returned back. What happens to the LDL receptor? It is free again. Again, more LDL is coming, and therefore it'll again be ready to receive that LDL particle. So millions of LDL particles, which we call these particles, small little particles that are there, they are absorbed by the LDL receptor present in the liver. And That helps degrade some of it, and therefore the LDL byproducts will be passed along into the bile, and only a small amount of LDL will be returned back. So your LDL, the net result is down. In other words, the blood leaving the liver will have less LDL. Now comes the PCSK9. Now this is the bad dude, if you will. So you have a wonderful sort of a mating relationship here between the LDL and the LDL receptors, correct? But PCSK9, when that comes into play, what happens is this is an enzyme. This enzyme, if it is present in high amounts, and there is a gene responsible which is present on one of the chromosomes that constantly makes PCSK9 in the tissues, and PCSK9, if that is high, it will interfere with this LDL receptor which is bound with LDL. So in other words, you have to have an LDL receptor and you have to have an LDL particle within the two in order to have this PCSK9 act upon it. Now if that happens, what happens is this LDL receptor is rendered degraded. So LDL receptor is dysfunctional now. It doesn't work anymore. And because the LDL receptor does not work in the liver anymore, at that point what happens is the net result of the LDL will constantly be rising, if at all. Why will it be rising? Because there is no functional LDL receptor present in the liver to remove the LDL. So constantly you're ingesting food or whatever you're having in your diet, your LDL will start rising because you do not have LDL receptors to remove the LDL because of this bad guy PCSK9. Hence, we need something to inhibit that PCSK9, and then came the philosophy or the concept of creating a PCSK9 inhibitor. So it's basically an inhibitor which is now present and now being marketed past 2 years. We have two of them. One is called, now these are tongue twisters by the way, evolucumab, I will call it, and the other one is called alirocumab. So these are the two agents. Both of them, they are monoclonal antibodies, and they are subcutaneous injections, and they have to be given every 2 weeks or twice a month. And again, the injections are barely, they're very, very small needles, like they're normally given by a small pen, if you will. And essentially it has a little needle there, and one can just give a subcutaneous injection. Total time of injection is about 9 seconds. For evolucumab, the dose is about 140 milligrams, and that's administered every 2 weeks, and that brings down the LDL concentration in your blood rather quickly. It is the only contraindication is if you're hypersensitive to PCSK9, one may not prescribe it, and the commonest reactions are obviously skin rashes, urticaria, and hypersensitivity reactions. But other than that, you don't react to monoclonal antibodies at all, because these are just antibodies against that enzyme which is already existing in your body. So they are basically antibodies which are now against your PCSK9. So once again, quickly, LDL particles are normally removed by LDL receptor. LDL receptors are present in millions of numbers, the more the merrier, and they help remove most of the LDL into the bile, and some LDL of course comes back, and that's called the entero-hepatic elimination, if you will. Now if you have LDL receptors with LDL present and then a PCSK9, which is the bad dude, I always say that's present, what happens is this LDL receptor is rendered dysfunctional, and if that becomes dysfunctional, your LDL starts rising, my friends. And because the LDL starts rising, then of course that leads to all the vasculopathies. And talking about vasculopathies, you'll have coronary artery disease, you'll have peripheral vascular disease, you may have stroke, which is cerebrovascular disease, or you may have renal hypertension, which is renal vascular disease. So all of these are important vascular trees which could be affected as a result of PCSK9, which is present in high numbers. So therefore, PCSK9 inhibitor will be the way to go, and these are the two drugs now available called evolucumab and alirocumab. Okay, and both are subcutaneous injections, and these are alternatives to statins, which have been around for a long time. Remember, these drugs are only indicated if you're not responding to statins, if you're not able to bring the LDL down sufficiently because while you have been on statins, or you're intolerant to statins. And sometimes in the heterozygous variety of the familial hypercholesterolemia, if you will, it's called FH, and the heterozygous variety will have a problem where the LDL is extremely high, perhaps more than 190, and these are the patients where you get premature coronary artery disease, if you will, or premature vascular disease. And these patients present at the very early age of 30, 35, 25 sometimes, and they've had a heart attack. And it gives the clinician a suspicion that there is something wrong with the LDL that's not coming down so rapidly, despite being on statins, and therefore one has to, and of course you can do genetic testings. So anyway, just quickly, I wanted to let you know MuniMeterHealth is primarily dedicated both for medical education, patient education. We are improving the education for our medical fraternity and the patients at large in order to improve the clinical outcomes. Thank you again for listening to me on this exciting subject, which is PCSK9 inhibitor, which is now a new modality to treat the hypercholesterolemia, which has been around for ages, of course, but statins have been around for several decades, and they've done a great job. But the fact is now we have another modality called PCSK9 inhibitor in the form of these two drugs. Thank you again for watching, and so long, and I'll see you again in